Today we are going to talk about acute rheumatic fever. It usually affects children, most commonly between 5 and 15 years of age, or young adults. Endemic in parts of Asia, Africa, and South America, it is triggered by immune-mediated delayed response to infection with specific strains of group A streptococci. Antigens that may cross-react with cardiac myosin and sarcolemmal membrane proteins. Antibodies produced against the streptococcal antigens and causes inflammation in the endocardium, myocardium, and pericardium, as well as the joints and skin. Clinical features. It involves multisystem that usually presents with fever, anorexia, lethargy, and joint pains. Latent period is 2 to 3 weeks after an episode of streptococcal pharyngitis. Diagnosis is made using the revised Jones criteria, 2 or more major manifestations, or 1 major and 2 or more minor manifestations, along with evidence of preceding streptococcal infection. Revised Jones criteria. Major manifestations include carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules formation. And minor manifestations include fever, arthralgia, previous rheumatic fever, raised ESR or C-reactive protein, leukocytosis, and first-degree AV block, plus supporting evidence of preceding streptococcal infection, recent scarlet fever, raised anti-streptolysin O or other streptococcal antibody titer, positive throat culture. Evidence of recent streptococcal infection is particularly important if there is only one major manifestation. Carditis. It involves the endocardium, myocardium, and pericardium to varying degrees. Incidence declines with increasing age, ranging from 90% at 3 years to around 30% in adolescence. It manifests as breathlessness with heart failure or pericardial effusion, palpitations or chest pain with pericarditis or pancarditis. Other features include tachycardia, cardiac enlargement, and new or changed cardiac murmurs, aortic regurgitation in 50% of cases, but tricuspid and pulmonary valves are rarely involved. Syncope with conduction defects. ECG changes include ST and T wave changes. In arthritis, it is the most common and early manifestation. Acute, painful, asymmetric, and migratory inflammation of the large joints typically affects the knees, ankles, elbows, and wrists. Pain characteristically responds to aspirin. If not responding, the diagnosis is in doubt. Skin lesions. Erythema marginatum. It occurs in less than 5% of patients. Lesions start as red macules, which are blotches that fade in the center but remain red at the edges. Occur mainly on the trunk and proximal extremities, but not the face. Subcutaneous nodules occur in 5 to 7% of patients. These are small, 0.5 to 2 cm, firm and painless. Best felt over extensor surfaces of bone or tendons. Typically appear more than 3 weeks after. Help to confirm rather than make the diagnosis. These are subcutaneous nodules, and this is erythema marginatum. Sydenham's chorea. It is a late neurological manifestation of acute rheumatic fever, appears at least 3 months after the episode of acute rheumatic fever. All the other signs may have disappeared. Occurs in up to 1/3 of cases and is more common in females. Emotional breakdown or changes may be the first feature, typically followed by purposeless, involuntary coriform movements of hands, feet, or face. Speech may be explosive or halting, Spontaneous recovery usually occurs within a few months. Investigations: ESR and C-reactive protein for monitoring progress of the disease. Positive throat swab cultures are obtained in only 10 to 25% of cases. Echocardiography shows mitral regurgitation with dilatation of the mitral annulus, prolapse of anterior mitral leaflet, may also show aortic regurgitation and pericardial effusion. Evidence of systemic illness can be seen with leukocytosis, raised ESR and CRP, and evidence of preceding streptococcal infection can be seen by throat swab culture, which shows group A beta hemolytic streptococci, also from family members and contacts. ASO titers, rising titers or levels of more than 200 for adults or more than 300 in children. Evidence of carditis can be seen by chest X-ray, which shows cardiomegaly and pulmonary congestion. ECG shows first and rarely second degree AV block, features of pericarditis, T-wave inversion, reduction in QRS voltages. Echocardiography shows cardiac dilatation and valve abnormalities. Management. Treatment strategies can be divided into management of acute attack, management of recurrent infection, and prevention of further infection and attacks. First, management of acute attack. Single dose of benzyl penicillin 1.2 million units IM and oral phenoxymethylpenicillin 250 mg 6 hourly for 10 days. Penicillin allergic patients can be given erythromycin or a cephalosporin. Analgesia optimally achieved with high doses of salicylates. Treatment is then directed towards limiting cardiac damage and relieving these symptoms. Bed rest and supportive therapy. This lessens the joint pain, reduces cardiac workload. Duration should be guided by symptoms along with temperature, leukocyte count and ESR. Should be continued until these have settled. Return to normal physical activity, but strenuous exercise should be avoided in those who have had carditis. Cardiac failure management. Mild heart failure usually responds to rest and corticosteroid therapy. Severe carditis, digoxin can be given, but its use should be monitored closely for AV block. Vasodilators and diuretics also may be used. If heart failure in these cases does not respond to medical treatment, valve replacement may be a necessary option. Management of Sydenham chorea. Sydenham chorea has responded to haloperidol. It requires long-term antimicrobial prophylaxis even if no other manifestation of rheumatic fever evolve. Complete physical and mental rest is essential because the manifestations of chorea may be exaggerated by emotional trauma. Prevention include primary prevention and secondary prevention. Primary prevention: 10 days course of penicillin therapy. About 30% of patients with acute rheumatic fever do not recall a preceding episode of pharyngitis. And for secondary prevention, it is directed at preventing acute group A beta hemolytic streptococcus infection, pharyngitis in patients at substantial risk of recurrent acute rheumatic fever. Primary prevention involves eradication of streptococcus from the pharynx by administration of a single dose intramuscular benzathine penicillin. In secondary prevention, patients are susceptible to further attacks if another streptococcal infection occurs. Long-term prophylaxis with penicillin should be given. Benzathine penicillin 1.2 million units intramuscular monthly. Oral phenoxymethylpenicillin to 50 mg 12 hourly. Sulfonamides prevent infection but are not effective in the eradication of group A streptococci. Long-term antibiotic prophylaxis prevents another attack of acute rheumatic fever but does not protect against infective endocarditis. Scanty prevention duration. If patient is having rheumatic fever without carditis, then scanty prevention duration at least for 5 years or until age 21, whichever is longer. Rheumatic fever with carditis but without residual heart disease, no valvular disease, then duration is at least for 10 years or well into adulthood, whichever is longer. If patient is having rheumatic fever with carditis and residual heart disease, persistent valvular disease, then duration is at least 10 years since last episode and at least until age 40 year, whichever is longer, sometimes lifelong. These are complications: aortic regurgitation or aortic stenosis,